here today. We have a nice crowd this morning. Thank you for being here. My name is Carl Gray. I'm the director of the Palliative Care program, and I'm honored to be introducing Dr. Christine Ritchie, and she's visiting us from Harvard. I also want to thank Dr. Rosenthal and Dr. Jeff Williamson for helping to make this visit possible from Dr. Ritchie. Dr. Ritchie is the Kenneth L. Meinecker Chair in Geriatrics and Director of Research for the Division of Palliative Care and Geriatric Medicine at Mass General Hospital. She's also establishing a Center for Aging and Serious Illness Research at MGH within the Mongan Institute, designed to bring together researchers across MGH and Boston community to improve the well-being of older adults and enhance the lived experience of those with advanced illnesses. Over the course of her career, she's built and led palliative care programs and run research programs focused on the intersection of geriatrics and palliative care, and she's the co-chair of the NINR-funded Palliative Care Research Cooperative and past president of the American Academy of Hospice and Palliative Medicine. Today, Dr. Ritchie is talking with us about her experience and research in home-based medical care. Please welcome Dr. Ritchie.
So good morning. It's a real joy to be here at Wake Forest University and to see many familiar friends and colleagues. And I have to say, this is probably the first time I've given grand rounds where I also have the real honor of knowing a meaningful subset of the fourth-year medical student class. So that just brings me particular joy that I get to have that experience as well. So today what I'd like to talk with you about is to go over with you what is going on in home-based medical care, because if you're thinking about a future in care for older adults, or frankly care for anyone with serious or chronic illnesses, this could be part of that future for you because of the things that have happened over the past 5 to 10 years that makes this more of a reality now than it has been in the past. So what we're going to do today is we're first going to talk about who are these folks who are homebound, who frankly would better be served by our going to them than they're coming to us. How are they important to sort of the well-being and care of the way we do healthcare in the United States, especially from the standpoint of value-based care? What are some models of care that have been demonstrated to be effective with that population? And then what might we do to improve the care of those services that we provide to that population? So that's what we're going to go over today. All right, so if you look at sort of the way we experience healthcare as patients, or how we provide healthcare as healthcare providers, generally speaking, we take care of folks in sort of different sort of buckets, right? And the first bucket is somebody comes in for preventive care, or they're diagnosed with one or more chronic condition. So you have high blood pressure, or you have hyperlipidemia, or you have arthritis, and you have one or more of these things. And for most people, that goes on for many, many years. And they come in for their primary care appointments, and maybe they start collecting a few specialty appointments, but that generally is care that's easily provided in an ambulatory setting, and that goes on for many years. Intermittently, people will experience times of an acute event, acute decline, or where they need rehab, and at that point they will, for weeks or months, experience a different kind of care in the hospital or in a rehab setting for those services. Then there's this period of time when people start collecting serious illnesses or illnesses that have a fairly significant negative impact on their functional status. And then after that, they come to the end of their life, and those services that they need also change. That's sort of the course of most of our experiences if we go through healthcare either as patients or as healthcare providers. But here's what the experience is actually if you look at what we provide for people, which is we offer a lot of services to people in the clinic during those eras when they are in the stage 1 through 3 of their chronic conditions. If they have an acute decline, frankly, our health system is set up for that. We work in hospital settings, and we're set up to provide care in that setting. But if you are in this space of longer-term functional decline and impairment, there's a care gap for you. And those are the people we don't see until they get back into the hospital for their ED visits or hospitalization or rehab. And then when they go back home, they're the folks that don't show up for their primary care visit. They're the ones who, if they do show up, they're coming in on a stretcher and they pretty much clog up the whole system, and they find it difficult and distressing, so they don't come back. And then at the very end of life, we do fortunately have services for people through hospice that allows for those services to be provided in the home. So what I want to talk with you about today is really around this care gap space and how we can do a better job providing care for essentially a group of individuals who until recently have remained completely invisible to the healthcare system. So as an example, I want to tell you about Joe. Joe is an 82-year-old person with dementia, heart failure, hypertension, hypothyroidism, and arthritis. I'm sure probably you can envision a Joe in your clinic. He lives with his pretty frail, increasingly frail wife in an old 2-story house. Their bedroom is on the 2nd floor. Their only son lives in Colorado. It could be California. That's usually where we have these only sons coming from, right, who swoop in and provide care at the last minute. And increasingly, this person is having multiple emergency department visits and hospitalizations for his heart failure exacerbation. And you're frustrated because as their primary care provider, he is not making it into clinic. You get the referral after the person is hospitalized, and it's just not working out. They cannot make it to clinic, in part because his wife no longer drives, and he, frankly, is not safe to go, and they don't have the social network to get them back into the clinic. So the question is, how do we provide better care for these people who are homebound, who are really having difficulty making it in? Well, first, we have to be able to identify them, and it turns out that is not easy. So why is it so hard to figure out who is homebound in the United States? There are a lot of reasons, but I want to highlight a few because I'm hoping some of you are going to help us do a better job in the future with identifying this population. The first is that they are not identifiable from any particular healthcare database. So if you're hospitalized, there's a lot of claims data that comes for you that's available to you there. If you're in the nursing home, you have to have a minimum data set, which is a federally required data set filled out for you when you're there. If you're getting skilled home health care nursing, which is an episodic benefit that only is offered to you in 30 to 60-day increments, you get OASIS filled out for you there. But all the rest of the time, if you're living at home and you're not receiving skilled home health care or hospice, there's no data about you. And there's no data to actually tell anybody sort of what your status is, except for the fact that you may be hopping in and out of the emergency department. And then they also don't receive any kind of consistent medical or social care. So these are the folks, again, who are not necessarily showing up in your clinic. They may or may not be receiving other kind of social support services that would make them available to be seen in any other kind of database. So they really are sort of in that under the radar, except for when they pop up with a crisis. And then the other dynamic is homeboundedness can be dynamic or partial. So if I've just had a hip replacement and I am not able to drive, I may be briefly homebound. But after that has elapsed and I've gone through rehab, then I may not be homebound any longer. So there's a dynamic aspect to it, although a lot of the folks that we take care of in home-based primary care and home-based palliative care have been homebound for a long time. And then the last item that's not on here but becomes very important when you think about predictive modeling is that we do a terrible job in the United States evaluating, assessing, and documenting functional status in the electronic health record. And since functional status is not visible in the electronic health record, it's very hard to even identify those people who are having trajectories of functional decline that might highlight for you that they need care in a different setting than they're getting currently. So we've worked very hard over the past 5 to 10 years to try to figure out how to articulate who these people are who are homebound. And we've pretty much been able to identify sort of 2 different groups, the group on the left being much easier, frankly, to identify than the group on the right. So there is a subset, it turns out it's about 7% of those who are homebound, who are actually receiving medical care in the home. And that's this group here on your left, which is we have data, claims data on them. We know when they're coming in and out of the hospital, and we can also tell chronically what kind of services that they're receiving. Then there's this middle group who they might not be getting home-based medical care, but maybe they are Medicaid eligible and they're getting home and community-based services. Well, we might be able to identify what kind of services they're getting or that they need services based on that information. But then there's this group, which is the predominant group, who need home-based medical care, and they are not getting it. They are high-risk superutilizers. They're frail, mobility challenged. That's the group that we really want to be able to understand better and provide better care to. And I think there's an increasing recognition that this is an opportunity for our health systems going forward. So this sort of served as a framework for us to try to understand this data, but it wasn't sufficient. So really what we had to do is say, where could we go that would offer us nationally representative data about older adults to see if we could figure out anything about homeboundedness. And fortunately, the only data set that would tell us that is the National Health Aging and Trends Survey data, which actually asks people about homeboundedness. So the National Health Aging and Trends Survey data is a population-based study. It randomly samples people, Medicare beneficiaries over the age of 65, and it includes, happily for us, both information about physical function, cognitive function, and they ask some interesting questions that sort of get at homeboundedness. Now let me show you how they ask these questions. What they do is they ask people over the previous month how often they're getting out of their home. And let's see if I can get this pointer to work. Maybe not so much. So I will just point with my finger. So there is a meaningful subset who never, ever go out of the home, period. They're not leaving their house. And that's about 1% of the entire population of Medicare beneficiaries. Then there's those who rarely go out. That's about 4.5%. Then there's this group who go out some days, but they never go out by themselves, or they only go out with help from other people. And then up here, there are people who are actually going out with some regularity, but again, they're never going out by themselves. They're only going out with help from other people. So those individuals, if that help from other people goes away, then they're also unable to go out. They're what we would consider the high-risk group. And when you actually look at what those numbers translate to in terms of the U.S. population, what it translates to is there are about 400,000 people in the United States who are completely homebound. These folks you are only seeing if they show up in the emergency department or in the hospital. There's another 1.5 million who are mostly homebound. And then if you include those individuals who are only getting out with the help of others and with great difficulty, then that adds another about 5.6 million people. These are what I call the invisible homebound. They are not easily represented in any other healthcare database, and there are many more of these individuals than there are in our long-term care facilities. So just as a reminder, for those of you who don't provide care routinely in nursing homes, in the United States, the total number of nursing home beds includes about 1.6 million people. So there are many more people who are homebound. If you just include these first two categories, then there are people who are in nursing homes. But the availability of medical care in nursing homes is much greater than the availability of medical care in the home. So let's learn a little bit more about this population based on the NHATS data. If you look at people who are homebound, and I just want to, for those of you in the back, this may be a little hard to see, the yellow, the orange is people who are completely homebound, and the gray are folks who are mostly homebound. So I just want you to focus on the orange and the gray in particular. What you can see is that people who are completely or mostly homebound are more likely to be Black. They're more likely to have a lower educational status. They're less likely to be married with a partner, and they're more likely to have lower income. So these are people who have social vulnerabilities in and of themselves, and then they have this additional vulnerability of being homebound. If you look at their healthcare status, they're more likely to represent their health as being fair or poor. they're more likely to be experiencing depression or dementia, not surprisingly, difficulty with mobility, and they are more likely to have been hospitalized within the past 12 months. Now, I want to highlight this point in particular. If you look at this population of people who are completely homebound, 60% of them have dementia. So this population who have dementia, who are homebound, it's not surprising if they have comorbid conditions, which most of them do, that they're starting to have difficulty navigating some of those comorbid conditions, and where they really need an additional structural set of services to support them. So to sum up, the homebound are not like you or me. They have more of a chronic illness burden, they have worse health status, poor mobility, many of them have limited social capital, and they're more likely to have depression or dementia. So why attend to this population? Well, first of all, this population is a very costly population. So I want to ask you a little quiz, okay? I'm hoping I can hear from those of you in the back, since you're so far away. Let's see, I'm not supposed to walk somewhere past a certain space here, apparently. So there is a population of people who are in that costliest 5% of Medicare, right? And if you had to guess what proportion of that group was in the last year of life, what percentage would that be? Let's hear some numbers. 80%, 50%, anyone else? One more guess. Okay, so we got between 30 and 80%. That's a meaningful range. So let's actually look at what the data tells us. It turns out that in the last 12 months of life, that's only 11% of the costliest 5% of Medicare beneficiaries. This is often misrepresented in the literature because of the way the data has actually been evaluated, which is when you look at the costliest people in the last 6 months of life who are hospitalized, that population is much more likely to be at the end of life. But if you look at the costliest 5% of Medicare beneficiaries, the predominance of them are in the short-term high dollar. This is the folks who are getting their transplants, their hip replacements, their shunts for their liver, kidney disease. But 40% of this population are in the persistent high dollar category. These are folks who are sick, who have multiple chronic conditions, who often have functional impairment, and they're sick for a long time. And this is the population we have not paid adequate attention to in the United States to try to figure out how we can provide better care for them. If you look at this costliest 5%, in addition, what you find is that if that population has multiple chronic conditions, then they are more likely to be hospitalized, no surprise. But look at what the additional effect is of having functional limitations or having significant functional impairment. Functional impairment plus multimorbidity is much more problematic for people, that thing that we don't test or assess in our healthcare records, than multimorbidity alone. So it's very important when you're assessing your patients for their care and well-being that you're paying attention to what's going on with their mobility, which you may not actually be able to evaluate if they're sitting in the in the hospital bed or if they're on your exam table without asking them what they're actually doing. In addition, these folks are very costly. So here again, just to highlight that if you look at people who just based on morbidity alone, folks who have only one chronic condition cost the system about $2,600 a year. When you start adding conditions, it starts going up, $4,000, $5,000. But when you get to 4 or more chronic conditions, then you're really getting to folks who are costly. Look what happens when you combine those chronic conditions with functional impairment. It increases the overall cost by more than $10,000 per year, just by virtue of that person having functional impairment. So my hope for you is just to highlight that this whole issue of functional impairment, which we don't talk about, is critically important for thinking about both cost and alignment of services. And then remember I mentioned to you that about 60% of those people who are homebound have dementia. It just so happens that folks who have dementia also are among the most costliest for our healthcare system. They're more likely to use skilled nursing facilities, more likely to be in the hospital than those who don't have dementia, and they're more likely to experience profound numbers of healthcare transitions, around 11 compared to those who don't have dementia, which is more in the range of 4. So who are these people who are the highest clinical risk and the costliest? They're those with multiple chronic condition, functional limitations, dementia, social and behavioral health challenges. Who does that sound like? It sounds like those people we just talked about, those people who are homebound. So my hope for you is that you understand now, number one, in just sort of broad strokes terms, who these people are who are homebound and why we as healthcare systems and as healthcare providers might want to be paying more attention to this population because of the illness burden they're experiencing and also their overall cost. Now, this has become particularly relevant over the past few years because of the growth of value-based care. So this comes from the Health Affairs blog from October of 2019 that shows that if you look at, this is by quarter, by the way, this starts in 2010, quarter 1, going up to quarter 3 of 2019. These are the growth of integrated care delivery networks of accountable care organizations, both commercial and Medicare accountable care organizations. And what you can see is that this number continues to grow. And if you also look at Medicare Advantage as a percentage of Medicare overall healthcare system integration, Medicare Advantage now constitutes close to a third of all Medicare, or I should say Medicare Advantage beneficiaries now account for about a third of all Medicare beneficiaries together. So value-based care and care that is thinking more about the overall cost of care as opposed to the cost in a particular health setting has become now increasingly our reality, which makes us start being able to think creatively outside of a fee-for-service model approach towards cost appropriateness. And that really changes the game for something like home-based medical care. So in accountable care organizations, and in my role at UCSF, I used to run our Office of Population Health clinical programs. We were constantly paying attention to this group that was at the highest risk for cost and the highest risk for untoward outcomes, and trying to figure out how we could do a better job providing care. Because people are increasingly focused on that population, it's changed the way we think about home-based medical care and given us a much greater interest as a community about its relevance to providing essentially higher quality care across the care continuum. So then my question for you is, what is home-based medical care? So this is my next quiz. Someone shout out for me, what is home-based medical care? Okay. Okay, you go to the patient doesn't come for you. And then I heard someone else say,
House calls.
House calls. Can you tell me what you mean by house calls?
Well, I've done them myself. You go to the family's home, you see the patient in the home, you do your history, your physical examination, you do your prescriptions that they may need, you evaluate where they're at in their care, and plan a follow-up for them.
So it sounds like primary care or medical care on wheels, right? Rather than them coming to you, we're going to them. Anyone else want to venture? What I didn't hear you say, which a lot of people do say when I ask them that question, is that's what skilled home health care does, right? How many of you have signed a 485 order for skilled home health care? Right, and you will, if you haven't, I promise you in the future you will. So people who are receiving skilled home health care, they are receiving care in the home. However, based on policy changes that are as recent as January of this year, it's becoming increasingly difficult to get skilled home health care for several reasons. First of all, the episode of care is shorter. It's gone from 60 days now to 30 days. And the reimbursement rates for people who get referrals from the community compared to the hospital has also dropped. So what this means is skilled home health care is becoming a more resource scarce benefit, and it can't substitute for everything you just described a house call does, which is to provide more comprehensive, holistic care for someone along their entire needs, including their medical care needs in the home. So just so we're all on the same page, when we talk about home-based medical care, we're talking about healthcare clinicians who are able to prescribe prescriptions, who are looking holistically at the medical care of that person, providing that care in the home. I wanted to just again highlight that because again, if you look at the spectrum of home-based care, not home-based medical care, there are a lot more people getting different non-medical forms of home care. And so the term home care can mean a lot of different things to different people. Informal services, home health aides, both paid and non-paid, both informal paid and informal non-paid, those fall into the largest proportion of services that are provided, about 10 to 15 million of informal services. Formal personal care services, these are provided through formal companies like Home Instead, about 2 million. Then Medicare skilled home health care, that's what I was just telling you about 3.5 million people receive services through Medicare home health. Look at this number. So remember how I told you there were about 5-point-some million people who are homebound? There are only about 500,000 of those people who are getting any kind of home-based medical care. And then hospital at home, a much even smaller number. Happily, there's some very interesting dissemination efforts around hospital at home, but we are not going to talk about hospital at home for today. So who are getting these kind of services and who's sort of implementing these kind of services? Well, it turns out, not surprisingly, value-based care models are the most interested in this because they recognize the potential cost savings of actually doing something that otherwise seems resource intensive, which is going to the person's home as opposed to them coming to you. So Medicare Advantage has probably been the most aggressive about applying home-based primary care and home-based palliative care, and also doing really interesting work around televideo care. I should put in here, and in honor of my friend Tom Houston, I will mention that VA has been extremely productive and aggressive about also offering home-based primary care. They probably had the best and most comprehensive home-based primary care program in the country for decades, and demonstrated its value over and over again. And they also had adopted home-based palliative care and virtual care. Managed Medicaid is slowly getting on the market, but frankly, the uptake is much smaller than we would have anticipated. And then slowly we're seeing Medicare fee-for-service, especially Medicare ACOs, start taking up home-based medical care. If you look, however, at who's getting home-based medical care across the country, and this is based on Medicare claims data, what you see is that it all depends on where you're lucky enough to live or not live, on whether or not you get it. If you live in a rural area, you're much less likely to get it than if you live in an urban area. If you're lucky enough to live up here or in Florida, you're more likely to get it. But there are whole big swaths of the United States where, by virtue of the culture or the uptake or the adoption, you're unlikely to get home-based medical care. The thing that's most dramatic to me is that if you're in the nursing home, you're 7 times more likely to see a primary care provider in the nursing home than if you are homebound. So the disparities between people who are homebound and people in nursing home is pretty profound. Now, how beneficial is home-based medical care or home-based primary care? Well, there have been a number of different studies. This is one that came out from the Journal of American Geriatric Society a few years ago. That's based on the MedStar home-based medical care program, which is out of Baltimore. And what they saw when they actually looked at overall total costs of care between their cases, those individuals receiving home-based medical care versus controls, is that there was overall about 17% lower costs. Not surprisingly, the outpatient costs increased, but the inpatient costs, which is where the predominance of the cost exists for most people, decreased for each of their beneficiaries. Particularly important is the Independence at Home demonstration project. How many of you are familiar with the Independence at Home project? Okay, it doesn't sound like very many, so I'm going to just tell you a little bit about it. The Independence at Home demonstration project was initiated about, in 2012, so about 8 years ago, as a demonstration project from the Center for Medicare and Medicare Services, and you had to apply to become Independence at Home program, and if you were selected, then you had to demonstrate cost savings. And there was very, frankly, straightforward eligibility criteria that included things like having received a hospitalization in the past 12 months, having at least 2 chronic conditions, and essentially being expected to live over a year with 2 or more functional impairments. So relative to a lot of the criteria that we use for these kind of services, it was actually fairly straightforward. The amazing thing is that, and so there were 17 sites that were selected to become Independence Home at Home demonstration projects, including one very large home care practice that's out of Troy, Michigan, that has an average daily census of around 25 to 30,000. And they're present in about 10 states. The average savings for these beneficiaries was about $3,000 per beneficiary in the first year. And in the first year, it showed about $11.7 million in savings. The 4-year cost savings just came out a few weeks ago. And what it looks like is if you look at the overall savings over 4 years of this demonstration project, it's about $100 million. And for a meaningful proportion of these sites that actually are very well run, they're seeing cost savings about $500 per month per beneficiary. So for a system, especially a system that's engaged in value-based care, this kind of model actually makes a lot of sense. There's also been systematic reviews looking at home-based primary care, both in the United States and in other countries. And not surprisingly, what you see is, in addition to reductions in utilization like ED visits and hospitalizations, is consistent improvements in patient and caregiver satisfaction and quality of life. So there's a patient-centered aspect to it in addition to a cost-centered aspect. Now, there's also a movement that's been going on around home-based palliative care, and in home-based palliative care, this has been a movement that's come out of sort of a different stream than home-based primary care. Home-based primary care sort of came out of outpatient care, outpatient primary care, outpatient geriatrics. Home-based palliative care came out of inpatient hospital-based palliative care, where people would send their patients home and realize they were not making it back to their palliative care clinic consultation visits, and then and they were not, quote unquote, ready for hospice. So there's been a new movement to look at home-based palliative care, and Richard Brumley and his colleagues developed a clinical trial to look at home-based palliative care out of Kaiser Permanente. And what they found is that with usual Medicare home care, which is skilled home health care, versus palliative care, which include the provision of medical care in the home and a physician in the home, that there was a reduction in ER visits, a reduction in hospital days, and a reduction in SNF days. When they did a secondary analysis to see and it was an interprofessional team that included nursing, social work, and medical care, which team member was the most important in reducing cost? Which one do you think it was? That's what I thought. Someone said social worker. It was actually the physician.
How about the nurses?
So when you looked at the overall benefit, the greatest benefit was in the presence of the physician going to the home. Why? That's the group that hasn't been there, whether it's a nurse practitioner or a physician or a physician assistant. It's that person who's able to provide medical care in the home that's been the gap, and it's that entry back into the care of that person that actually makes the difference, keeping them from going into heart failure, answering their calls at 2 a.m. in the morning, trying to make decisions about whether or not they go to the ED, that makes the difference for that population. This is another study that came out from Dana Lusbader's group, where they looked at a home-based palliative care program in the New Jersey, New York area, and they were able to show that when they looked at their costs, they also had a reduction in costs of around $10,000 in the last year of life when they compared home-based palliative care to home-based primary care. What's really fun about Dana's program is that she's very effective in using video care. Dana was a critical care doc before she became a palliative care doc and is very comfortable with sort of dealing with acute situations and has figured out how to use video care in a way that really subsidizes and supports her healthcare team. Now, how many of you are familiar with primary care first? A few of you. Okay. This is something that's just come into being in the past 6 to 12 months by the Center for Medicare and Medicaid Services. And it was created as a way of trying to address complex illness care. And primary care first has been, there's been a lot of conversations and policy work around it through the American Academy of Hospice and Palliative Medicine, SGIM, the American Academy of Home Care Medicine, all these American Academy of Family Medicine, all these groups who care a lot about these complex, seriously ill patients who currently are not getting adequate care. And so what CMS did is they came out with this thing called Primary Care First. And what Primary Care First does is it identifies people who are seriously ill, who are quote unquote unstable, and offers additional reimbursement for provision of services of any kind for that person to enable them to get better care, including home care. Now, there's one real problem, however, with Primary Care First, is that they only expect the length of stay in any kind of home-based care model to be 8 months. Well, a lot of these folks are living longer than 8 months, and a lot of these folks are either not interested in or not appropriate for hospice after 8 months. So the weird thing about Primary Care First is that it's creating a new model that doesn't actually address the real longitudinal issues of home-based, of homebound populations, and sort of putting this sort of Band-Aid on it. And so there was a, this just tells you about Primary Care First, which it's the selection for, you had to apply, just like you had to apply for some of these other programs. The application process just closed down about a month ago, and it will start in January of 21. But already there's a lot of worry on the part of people who are providing care for those who are homebound that this actually is not our solution and it will actually disenfranchise more people than it will help. So this blog came out 2 days ago, and if you're interested, you can find it on Health Affairs. And it basically said, the problem with Primary Care First is it doesn't deal with these people who don't stabilize after 8 to 12 months. It is only appropriate, the one thing I failed to mention is it's only appropriate for people who don't have primary care now. So what if you actually do receive primary care, but you're just not able to make it to your primary care provider? What about those folks? They remain disenfranchised. It uses very complex eligibility criteria, and it doesn't take into account the vast sort of demonstrated benefit that the independence at home movement has showed. And their argument from this blog was, we should just be doing home-based medical care. That would be a much sort of more effective approach using the independence at home criteria than this Primary Care First model. Now, the other group that has really started to get interested in home-based medical care for all the reasons we just discussed are venture capital companies. So in the Bay Area, pretty much every third month, some new company is being formed that's trying to figure out how to crack the nut around home-based medical care. Many of them are not focused on the population that we just talked about. So there's a company called Heal that's focused on Google employees who don't want to be seen during work hours, and they can be seen at home at the end of the day. And there are other kind of concierge practices, but there's also a growing number of practices like MedZed, Iora Health, Landmark, CareMore, that are all focused on the very population that we've been talking about, and they're trying to do a better job than we're doing right now, which frankly is not very hard because we're not doing a very good job in providing this care. But I think what I'm trying to point out for you is that this isn't just sort of an interesting idea. There's a growing amount of traction, and I think for those of us who are in academic health centers, we need to be getting on this bandwagon and doing a good job and thinking about how we can provide high quality care for this population as well. So where should we go next? Well, I'd like to talk with you about some things that we've been working on where we see real gaps in still this space around home-based medical care, both among those people who are homebound and those who are caring for them. What we saw first when we were sort of looking at this space about 8 to 10 years ago is that first we need to shine a light on those people who are homebound and on the whole concept of home-based medical care. When we went to NIH, we went to foundations, none of them actually even knew what home-based medical care or home-based primary care was. They thought it was something quaint like Marcus Welby or Dr. Quinn Medicine Woman that Carl Gray reminded me was also a home care provider. And I'm sure some of you could come up with some more recent TV series that sort of highlights people who provide care in the home. But they didn't see it as being highly relevant, applicable to populations right now. So that was sort of our first opportunity. But then our challenge is, it's a vulnerable thing to be homebound and to have healthcare providers coming to you. Nobody's looking over their shoulder. Where's the accountability? How do we know they're providing high quality care? Could they be taking advantage of these populations? So having a very strong quality framework becomes very important for this population. And so part of our work has also been related to creating a better concept of what quality looks like. So our game plan in addressing this was first to learn more about home-based medical care practices. Second was to create a network so that we could start actually developing and testing measures. Third, creating a registry, and then developing measures that actually make sense for home-based medical care. If you had to guess right now, based on all those PQRS measures that you have to use for your quality metrics in your primary care practice or in your specialty practice, how many of them relate to the homebound? What proportion would you say that might be? Someone said 0. Actually, happily it's better than 0, but it's not 100%. And in fact, if you look at the PQRS measures, there's only about 30% of PQRS measures that are potentially appropriate, but only 50% of those 30% even have home care visit denominator codes. So even if you wanted to use them, you couldn't because they haven't been tested in this population. In fact, none of the quality measures have been tested in this population. So we have this big disconnect between saying, yes, it's important for us to provide quality for this population, but not having measures that help with that. So we've been developing a practice-based registry in concert with the Center for Medicare and Medicaid Services to help home-based medical care practices with benchmarking, created a learning community, quality reporting requirements, and then a way for people to move into this field. And this provides you with just a quick overview of what we've been doing since 2013. We started with creating a network because there are exemplar practices out there that are doing good work. We developed a home-based primary care set of quality indicators based on a number of different stakeholder guidelines. We started creating measures. We got our first measures endorsed by NQF last year around functional and cognitive impairment. And now we're trying to sort of spread the word to people like you and others about the importance of this population and how, as a healthcare community, we can do a better job providing their care. This network that I mentioned at the beginning started with 12 exemplar practices. Now, there are many more than 12 exemplar practices, but we got those practices who were both either a part of the Independence at Home demonstration project or who are known to have high quality service provision, and asked them, from your vantage point, what constitutes high quality care. And then we also talked to 3 different professional societies, the American Academy of Hospice and Palliative Medicine, the American Academy of Home Care Medicine, and the American Geriatric Society, and had representatives from those societies tell us what they thought constituted high quality home care medicine. And then we had a number of consumer and patient advocacy groups, along with patients and caregivers who were receiving care in the home or who were homebound, tell us what they thought constituted high quality care. And based on that, we developed a series of quality domains, standards. Ultimately, this stands for quality indicators, and our first sort of measure set, which we then created to form this registry, which is now a CMS qualified clinical data registry, which if any of you are interested, you can participate in. And in fact, Wake Forest's home care program did participate in use of this registry and in trying to figure out what these standards look like for the Wake Forest home care program. And then what we did is we tried to get this word out. These are the 10 domains of quality care. Some that are particularly unique to home care medicine is safety. So this is safety for the patient and their caregiver and for you, the healthcare provider. It was not uncommon when I was providing home-based primary care in Birmingham, Alabama, that my patients would have their guns laying out on their bedstand when I was come to visit them. And that was a safety issue for them. It was a safety issue for me. And so making sure that you have plans and quality measures around safety becomes an important issue. There are other things like falls, risk, et cetera, of course, that we think about with respect to safety. There's also issues around access. Is that person able to access someone to guide them around their medical care 24/7? It's remarkable how few people have access to this kind of service, but it's the difference between whether or not someone gets hospitalized or put in the ED or not. And then finally, we're working with a large set of practices to test these measures, and as of September of this year, initiating our third learning collaborative. Where else should we be going? I believe that we are not doing a good enough job leveraging all the technology that we have available to us to apply that in the home care space. There's these gadgets now called GrandPads. Have any of you heard of GrandPads? Some of you have. That's awesome. And they actually, I've noticed that they advertise just like on regular TV and stuff. But GrandPads are essentially iPads that are easy to hold, have sort of more font-friendly visualization, and are also easier to navigate and can be used very easily to provide medical care. And if you can help your home care patient use a GrandPad or some equivalent thereof, then in those in-between times, in between home visit times, you can have ready access to provision of video care. In addition to that, you can provide video care with them and that son in Colorado at the same time so that you can be engaging in conversations around what makes sense for treatment, what makes sense for next steps. So I think we could do a much better job with that. And happily, some of these companies that are now being started around home-based medical care are starting to use more technology. Remember how I talked about how hard it was to identify these folks? That's still a conundrum for us. We're still trying to figure out how to do a better job identifying this population. And increasingly, as we integrate functional assessment measures into our electronic health record, I think we'll find it much easier, especially if we look at trajectories of functional decline, to identify this population going forward. Home-based medical models have often been in silos, and even at MGH, we have our home-based primary care program, our home-based palliative care program, our hospital at home program, our medical obs unit program. They're all disconnected. They would do a much better job of provision of care if they were more coordinated. And this is true for a lot of healthcare systems. We need to do a better job with coordination. And then finally, how do we evaluate these so we really know that we're providing high quality care? It's nice to show that we're reducing ED visits or hospitalizations, and that's important, but are we actually reducing caregiver distress? Are we improving patient and caregiver well-being? Those are other important questions for us to ask. So let's go back to Joe. He was the one we talked about at the beginning. He starts to receive home-based primary care. When you as the healthcare provider go into his home, you see that there are medications all over the place. Many of them have expired. You don't know what he's taking. He doesn't know what he's taking. And basically, just by simplifying his medications and making clear what he's supposed to take and offering a simple solution, surprisingly, he stops being seen in the ED for his numerous heart failure exacerbations. He knows now, and his wife knows, what to do when his weight and dyspnea increase before it gets out of hand. He's getting the appropriate durable medical equipment and safety issues addressed at home. And over the previous 6 months, compared to the 6 months when he didn't get primary care, home-based primary care, he only has one ED visit, and it's for an appropriate ED visit for a kidney stone. He has improved quality of life, and now he's intermittently able to putter around in his backyard garden, which he hadn't been able to do for many for many months before. So to summarize, the homebound are an underappreciated group of people who are many in number and who need better care in our healthcare system. They're important to all value-based models. They also are important when you integrate home-based medical care in reducing overall cost and improving outcomes. And they have the opportunity to improve, we have the opportunity by providing home-based medical care to improve quality across the entire care continuum. And then finally, I believe for many of you, especially those of you who are fourth-year medical students or just in your residency and fellowship, that this can be your next frontier for providing high-quality care for seriously ill people in the place where they want it most. So thank you, and I'm happy to answer questions.
All right. Well, thank you, Dr. Ritchie, for that educational and thought-provoking talk this morning. I do want to open it up for questions. And for folks that I know have to run out to clinical duties, if you want to grab one of the feedback and review forms, please grab one of those and fill those out as well.
Christine, thanks for an absolutely, fabulous talk, on a topic that, I think, unfortunately, we haven't really devoted enough, time and effort to. So you highlighted, that there's a number of very encouraging programs out there, demonstration projects. So we are, as a health system, we're on the verge of sort of integrating, with a much larger partner and the potential, to have one of the largest health systems, in the country. What have you learned about, the scalability of interventions, and what are the key ingredients to go beyond some of these initial demonstration projects, many of which were jump-started with, some degree of external funding?
Right. So I think the scalability, there's two different dimensions of scale. One has to do with very careful attention to cost and savings. So monitoring that, evaluating it, and paying attention to it in real time. So that's one piece of it that's very important, and I think has historically not been done very well. And then the other piece is paying close attention to actually what constitutes high-quality home-based primary care and making sure that's being implemented. So oftentimes, I see home-based primary care programs put together sort of with duct tape and a little extra spackle, and there's not all the pieces there, frankly, that will optimize their ability to demonstrate savings. And one of the biggest is 24/7 coverage. So I basically say you don't have a home-based medical care program if you're not providing 24/7, at least telephone access to care. And not only that, if it's not interprofessional. So the Independence at Home demonstration project actually provides some scaffolding around what I would consider the bare minimum expectations for quality. And there are a lot more that need to happen, but I think both of those are important. And then evaluation of other more soft measures that aren't going to be seen with some of the cost measures. But both of those pieces are very, very important, and they have to be done in real time. So one of the things that Dana Lusbader does that I love, and which we did at UCSF, is every time a patient who is a homebound patient in our program got hospitalized, we asked ourselves, what happened? Was there anything we could have done as a team in our community partners to have kept that from happening? And engaged in sort of continuous sort of reflection around that as a learning opportunity for ourselves and how we could actually build our program better. So I feel like there's both this sort of ongoing monitoring piece, and then there's also the quality scaffolding piece.
Thank you very much, Christine. I don't know if you have the data, but I'm guessing that people that are homebound are evenly distributed throughout America, not necessarily more in cities than rural. And I'm guessing that most of the homebound care we provide is to people not too far from the medical center.
Right.
Do we have any idea if we can actually provide cost savings for those in the rural setting?
So the VA is the only one that's done a very good job with providing rural home-based primary care, and they've used satellite methodologies. So what they do is they have sort of the mothership program, and then they have these satellite programs, and they have been able to demonstrate positive impact for those populations as well. But it's hard work. I mean, I would be, it would be probably not reasonable or appropriate to say that that's easy. If you're in Nebraska, Montana, Wyoming, providing house calls in that population where there's large spaces of, is not inconsequential, which is where I think the video telecare can be important. So if you're able to set up televideo care with patients and they can know how to use it, then yes, you still may have to go visit them, but you might not have to go to visit them quite as often. Yeah. Tom?
Thanks, Christine. That was great. Your last slide, when you followed up with your case, made me think back on there's so many different ways to save. And one is to reduce costly things like hospitalization, and another is to reduce doing things that may not add value. So you were talking about reducing his polypharmacy. So when you think about the cost savings, has anybody tried to parse out how much of it is like stop doing stuff that doesn't help?
So that's an awesome question that we haven't actually evaluated. And I think, if you look at, for example, the 4 M's of age-friendly healthcare, which includes addressing medications, mobility, mentation, and what matters, you would think that those things around medication and what matters, which is, clarifying goals of care, making sure there's alignment around preferences and treatments, medication simplification, that all those things are important. That has not been parsed out. And this reminds me of a lot of what we see in palliative care, which is we test palliative care and we say, it works. And we say, well, what is it? And we still haven't figured out what it is. And so that is an opportunity, I think, as part of our health services research going forward, is to try to understand what is in the syringe and what parts of the syringe are most important for different populations. Yeah.
Thank you very much for your long years of work on this. January, there was the Camden randomized trial for hotspotters, which was very sobering. Your thoughts on why that model failed? And it seems like your model, if we were visualizing a multi-variable model with different weighting, I think you implied 24/7 access, big weight, maybe a trusted authority figure. It has to be a doctor. And then teams. So what's the interaction? So is it a doctor leading a team, or is it a doctor with the ability to communicate well with other team members, no look passes and all that?
And by the way, I really mean a clinician who has the ability to prescribe, to both assess medical situations and engage in prescribing. So nurse practitioner member of the team, PA member of the team have also been demonstrated to be very effective in provision of care. But I'm very assertive about using the word medical, because it is the provision of that medical care that often is not present in a lot of the other current healthcare models provided in the home. So the social model of care, which is very important, things like, home and community-based services by Medicaid, they often don't have the medical piece, and what brings these people into the ED. In terms of which part can be weighted the most, this sort of gets back to Tom's question, which is what's in this, or was it your question, Tom? Yeah, what's in the syringe? And I'm not sure that we know what to weight most sort of to the most degree. I'll tell you, in our program at UCSF, when we tried to parse out what we thought were sort of the most key ingredients in the secret sauce, it was having high-quality clinical care providers who were engaging in medication simplification, who did attend to the relationship with the patient and their healthcare providers, many of whom in our practices were not English-speaking, and who had non-English-speaking caregivers. In addition to that 24/7 access, those seem to be the most important, but I don't think we actually know truly the answer to that question. Yeah.
All right. Any other questions? Great.
Thank you.